In the next section on acid-base physiology, we will go through the first of the 4 simple acid-base disorders, metabolic acidosis. Metabolic acidosis is caused by a decreased bicarbonate concentration in the blood. Metabolic acidosis can result from an increased production of fixed acids, such as ketoacid or lactic acid, ingestion of fixed acids, such as salicylic acid, the inability of the kidneys to excrete the fixed acids produced from normal metabolism as seen in chronic renal failure, or from a loss of bicarbonate via the kidneys or the gastrointestinal tract. Table 7-4 gives the common causes of metabolic acidosis according to different underlying etiologies. The arterial blood profile seen in metabolic acidosis is as follows. The pH is decreased as the free hydrogen concentration is increased. The bicarbonate concentration is decreased, and the respiratory compensation should lead to a decreased PCO2. The following sequence of events occurs in the generation of metabolic acidosis to produce this blood profile. Although metabolic acidosis can be caused by a frank loss of bicarbonate, as in diarrhea and type 2 renal tubular acidoses, most often it is caused by an excess of fixed acid in the body. So let's walk through an example of a gain of fixed hydrogen. Excess fixed hydrogen is accumulated in the body either through increased production or ingestion of fixed acid or from decreased excretion of fixed acid. The excess fixed hydrogen is buffered in both the ECF and the ICF. In the ECF, the hydrogen is buffered primarily by bicarbonate, which produces a decrease in bicarbonate concentration. The decrease in bicarbonate concentration will cause a decrease in pH, as predicted by the Henderson-Hasselbalch equation. In the ICF, the excess fixed hydrogen is buffered by organic phosphates and proteins. To utilize these intracellular buffers, hydrogen first must enter the cells. Hydrogen can enter the cells with an organic anion such as ketoanion, lactate, or formate, or it can enter the cells in exchange for potassium. When the hydrogen is exchanged for potassium, hyperkalemia occurs. The next step is respiratory compensation. Decreased arterial pH stimulates peripheral chemoreceptors in the carotid bodies. They respond by causing hyperventilation. Hyperventilation will lead to a decreased PCO2. This is the respiratory compensation for metabolic acidosis. To appreciate why this is a compensatory response, once again examine the Henderson-Hasselbalch equation. The pH is equal to the pK plus the log of the concentration ratio of the bicarbonate to the PCO2. We have already identified that the primary disturbance is the bicarbonate concentration that has gone down. In order to increase the pH, we need to have a corresponding fall in the PCO2. The primary disturbance is a decreased bicarbonate concentration, which by itself would lead to a profound decrease in pH. The respiratory compensation, or hyperventilation, decreases the PCO2, normalizing the ratio of the bicarbonate to carbon dioxide concentrations and bringing the pH close back to normal. The last step is renal correction. Buffering and respiratory compensation occur quickly. However, the ultimate correction of metabolic acidosis occurs in the kidneys and will take several days. The excess fixed hydrogen will be excreted as titratable acid and ammonium. Simultaneously, new bicarbonate will be synthesized and reabsorbed by the kidneys to replace the bicarbonate that was consumed earlier in buffering. In this way, the blood bicarbonate concentration will be returned to normal. Once again, Table 7-4, causes of metabolic acidosis. Let's walk through a case. Clinical physiology of diabetic ketoacidosis. This is given on page 317 of the text. A 56-year-old woman has a 15-year history of type 1 diabetes mellitus, which has been controlled by careful dietary monitoring and treatment with subcutaneous injections of insulin twice daily. A recent viral illness results in loss of appetite, fever, and vomiting. She becomes short of breath and is admitted to the intensive care unit of the hospital. Physical examination reveals that the woman is acutely ill. Her mucous membranes are dry and she has decreased skin turgor. She is breathing deeply and rapidly. A urine sample contains glucose and ketones. Laboratory tests on her blood yield the following information. The arterial blood gas reveals a pH of 7.07, a PCO2 of 18 millimeters of mercury, and a bicarbonate concentration of 5 milliequivalents per liter. The venous plasma results show sodium of 132 milliequivalents per liter, chloride of 94 milliequivalents per liter, potassium of 5.9 milliequivalents per liter, and a glucose concentration of 650 milligrams per deciliter. The woman is given an insulin injection and an intravenous infusion of isotonic saline solution. Her blood values and her breathing return to normal within 12 hours after beginning treatment. How did this occur? And let's walk through further explanations. The woman's diabetes mellitus was well controlled until acute viral illness precipitated an episode of diabetic ketoacidosis. Her elevated blood glucose level of 650 milligrams per deciliter, and recall the normal is approximately 80 milligrams per deciliter, and the presence of glucose in her urine are evidence that her diabetes mellitus is not being controlled. She is excreting glucose in her urine because the blood glucose concentration is so high that the filter load has exceeded the reabsorptive capacity of the renal tubule. On admission, the woman has arterial blood values consistent with metabolic acidosis, that is, a decreased pH, decreased bicarbonate concentration, and decreased PCO2. Metabolic acidosis in uncontrolled type 1 diabetes mellitus is caused by excessive production of the fixed acids beta-hydroxybutyric acid and acetoacidic acid, both ketoacids. The absence of insulin causes increased lipolysis or increased fat breakdown. Fatty acids, the product of lipolysis, are then converted to ketoacids beta-hydroxybutyric acid and acetoacidic acid. Recall that the presence of ketones in her urine supports the diagnosis of ketoacidosis. These excess fixed acids are buffered by extracellular bicarbonate. This ultimately decreases the blood bicarbonate concentration and decreases blood pH. The decreased PCO2 is a result of hyperventilation, the rapid, deep breathing that is manifested. A respiratory compensation for metabolic acidosis, also known as Kussmaul's respirations. The question remains, does the woman have a simple metabolic acidosis, or does she have a mixed acid-base disorder? To answer this question, the rules of thumb are used to calculate the predicted change in PCO2, or respiratory compensation, for the measured change in bicarbonate, and we will refer to Table 7-3 for the calculation. For simple metabolic acidosis, the rules state that a decrease in bicarbonate of 1 milliequivalent per liter will produce a decrease in PCO2 of 1.3 millimeters of mercury. The woman's bicarbonate is 5 milliequivalents per liter, which is a decrease of 19 milliequivalents per liter from the normal value of 24. Thus, the predicted change in PCO2 for this change in bicarbonate is 25 millimeters of mercury, or 19 times 1.3. The predicted change in PCO2 now is compared with the actual change in PCO2. The woman's PCO2 is 18 millimeters of mercury, which is 22 millimeters of mercury lower than the normal value of 40. The predicted change in PCO2 and the actual change in PCO2 are close and suggest that the only one acid-base disorder is present, that is, metabolic acidosis. The plasma anion gap provides useful information in the differential diagnosis of metabolic acidosis. The woman's anion gap is calculated as follows: the sodium concentration minus the sum of the chloride and the bicarbonate concentrations. Thus, the anion gap is elevated at 33 milliequivalents per liter. Recall the normal value for plasma anion gap is between 8 and 16 milliequivalents per liter. At 33, the woman's anion gap is severely elevated due to the presence of unmeasured anions. In other words, bicarbonate, a measured anion, is decreased and has been replaced by unmeasured anions to maintain electroneutrality of the plasma compartment. Considering the woman's history of diabetes mellitus and the presence of ketones in her urine, these unmeasured anions most likely are beta-hydroxybutyrate and acetoacidity. The decreased skin turgor and dry mucous membrane suggests ECF volume contraction. The cause of her ECF volume contraction is the loss of solute and water in the urine due to an osmotic diuresis of glucose. Because the woman's blood glucose is so high, a portion of the filtered glucose cannot be reabsorbed. The unreabsorbed glucose then acts as an osmotic diuretic, and sodium chloride and water are excreted along with it to cause ECF volume contraction. Hyponatremia, or decreased blood sodium, is often seen in diabetic ketoacidosis, and that can be explained as follows. Because the woman's ECF glucose is markedly elevated, her ECF osmolarity also is elevated. Recall that glucose is an osmotically active solute. As a result of this hyperosmolarity of the ECF, water shifts out of the cells to achieve osmotic equilibration between the ECF and the ICF. This then dilutes the solutes in the ECF, decreasing the blood sodium concentration. The woman also has hyperkalemia, or increased blood potassium concentration. The relationship between acid-base balance and potassium balance is often complicated, but particularly so in cases of diabetic ketoacidosis. The most likely cause of her hyperkalemia is a lack of insulin. Recall from Chapter 6 that insulin is a major factor causing a shift of potassium into cells. In the absence of insulin, potassium shifts out of cells and produces hyperkalemia. The other factor contributing to hyperkalemia is the hyperosmolarity, which is presumed to be a result of the elevated blood glucose. As water shifts out of the cells to achieve osmotic equilibration, it carries potassium along with it. This likely results in further hyperkalemia. The metabolic acidosis is most likely not a factor in causing her hyperkalemia because when hydrogen enters the cells to be buffered, it enters with the ketoanions. Thus, it need not be exchanged for potassium. Treatment in this case consists of an injection of insulin, which decreases the woman's blood glucose level, corrects her ketoacidosis, and corrects her hyperkalemia. She is also given an intravenous saline solution to replace the losses of sodium and water resulting from the osmotic diuresis. This concludes this section.